Hello.
Hello. Hi, Rukayat. How are you?
Hi. I just wanted to make sure you can hear me. Yeah.
Yes, I can hear you. Just to
Okay.
confirm if my slide is visible and I'm audible to all of you?
Yes.
That's great. That's perfect. All right. So before we begin with the OSCE, let me just welcome everybody else who has come here for the session. A very welcome to all of you from the entire team of MedExam Expert. Thank you so much for being with us today. We're really happy that you're all here with us. Today, we will be dealing with a very interesting station, a very interesting negotiation station, and we have Dr. Rukayat with us, who's going to be playing the candidate, and I will be the role player. Okay, Rukayat, do you have any questions about how we're going to go forward from here?
No, it's fine.
All right. So for everybody else, we are going to be dealing with the labor and delivery module, and this is going to be a negotiation station. Rukai, do you suggest we wait for 5 more minutes so people can join in, and then we'll kickstart the station? What do you think? All right. Hi, Pablo. How are you? I hope you're doing well. Good evening. Good to see you here. Long time. Thank you. Hi, Anam. Hi, Darshana. I hope you're all doing well. Hi, Shaima. I hope you're well. Hello, Mariam. Thank you so much for being with us today. So, do we have anybody here who's recently cleared the Part 2 exam? Or, Hi, Darshana. How are you? Just to understand, have you guys cleared your exam recently? The last Part 2 exam results that came out in July? Oh, that's great. That's great. So you're fresh with your clinical knowledge. That's amazing. Okay. Pogula, I know you cleared in Jan. I know you. That's great. All right. So, Rukayat, I believe we can begin with the station. Are you ready?
Yeah, I'm ready.
That's perfect. Okay, so just to let everybody know, the station is going to be for 12 minutes and you will have 2 minutes of reading time, Rukayat, and this is your station. Here is your timer. There goes your 12 minutes. You have 2 minutes of reading time. Okay, once your reading time is over, we'll begin with the station. Let me know when you want me to change the slide, please.
Yeah.
We have another slide. This one.
Okay. I haven't finished reading that.
Oh, I'm sorry. Just let me go back. There you go.
Okay. Yeah.
You want the next slide?
Yes. Okay.
You have 20 more seconds, utilize it well, and then we'll begin your station. Okay, you may begin.
Okay. Hi, hello. My name is Dr. Rukayat. I'm one of the doctors in the clinic today. I'm working with a consultant. Can I confirm your name and your age, please?
Hi, doctor. My name is Rita Skeeter, and I'm 30 years old.
Okay.
33 years old.
How do you want me to call you?
Rita is fine.
Good to meet you, Rita. I understand you were sent in from your GP today because you have some questions for us in clinic. Is that right?
Yes, that's right.
Okay. By the end of this consultation, can you tell me what you're expecting that I could do for you?
Well, doctor, basically, I just want to talk to you regarding, how I'm going to deliver this baby, the mode of delivery. Basically, that's the whole agenda of this meeting today.
Oh, sure. By the end of this consultation, I believe we should be able to answer your questions and make a plan going forward in this pregnancy. Would you like me to ask you a few questions just to know more about you, about this pregnancy before we make a management plan?
That's fine.
Good. Do you have any concerns today?
Well, there's no concern as such, but I had a terrible labor the last time. It went on forever. It was very painful, and then I had a 3rd-degree, 4th-degree perineal tear. They took me in, they sutured. Basically, I've made up my mind that I do not want to have a normal delivery again. I pretty much want to have a cesarean section.
Oh, that must be very difficult for you. Sorry this has happened to you. And how is your baby from your little one at home?
Oh, my daughter is fine. She's doing very well, but the process of delivery, the labor, it was very painful. It was very traumatizing, and I just do not want to go through that ever again.
Okay. How has this pregnancy been so far? Have you had any concerns?
No, it's been fine. Everything's been okay.
Baby moving all right today?
Yes.
Okay. And in your last pregnancy, can you tell me, did you have to be induced or you went into labor by yourself?
Oh no, they gave me some tablets. Yeah, some
Okay.
tablets that they put inside, and they had to do that 3 times. And after that, it felt like I was in pain for an entire day, after which I became, fully dilated, and they told me to start pushing 3 hours after I became fully dilated. And I pushed and pushed, and my daughter came out, but then they told me that I had this horrendous tear and they had to take me into suture. It was just traumatizing.
Oh, okay. And what sort of delivery did you require any assistance at this delivery?
Assistance? No, I did
In
not.
in
Normal
in
delivery.
form of having a cup on the baby's head or like a spoon to deliver the baby with the help of the doctor?
No, they did not.
Okay. And how was the recovery period following this?
It was quite painful.
Was there any infection? Did you notice any infection afterwards?
No, there was no infection.
And were you able to pee afterwards?
Yes, I could be, yes.
And no bowel problem. You could move your bowels after the procedure.
Not immediately after it, but yeah, after a couple of days I did.
Okay, that's good. And how is the area? Did he heal very well?
Yes, now it's fine. It's been
Okay.
3 years, so it's fine now.
Are you otherwise fit and well?
Yes, otherwise I don't have any other problems.
You don't have it. Okay. Aside the delivery from down below, have you had any other surgery in your tummy or from down below?
No, I don't.
No. Do you have any allergies so far? Do
No,
you know
nothing
about?
that I know of. No.
Okay. And in terms of blood group, would you know your blood group?
Yes, I'm B positive.
Okay. And in terms of blood transfusion, is that something you will be willing to have in this pregnancy if you should need it?
No, but do you think I would need a blood transfusion?
Well, it's quite difficult to say, but the optimal goal in during labor and delivery for every woman is to try and control a bleeding. But some women sometimes, because of the circumstances surrounding their delivery, might require some blood transfusion. So I
I
just
see.
want to know beforehand if it's something you will be willing to have. Of course, if you don't need it, we wouldn't give it to you.
All right, right. No, I don't have any problems with it.
Okay. I can see from what you've told me today that this pregnancy has been fine, and you didn't have any complications going forward from your last delivery. Am I right saying so?
Yes.
Okay. And in this pregnancy, the last scan you've had, is he saying the baby is growing normally?
The midwife didn't seem to have a problem. She said the baby was fine.
Okay, okay. I understand you had you had your baby in London. We can request for the notes so that we can go through it and just to be sure what exactly happened during your delivery and how this 40 degree was managed. However, going forward today, I would like to examine you, examine your tummy just to make sure baby is growing the right size, if that's okay with you.
That's fine.
It's okay. And also examine you from down below to just to make sure that everything is fine also.
If that's necessary, all right.
Okay. As regards your plan for delivery, choosing a cesarean section is reasonable enough considering the fact that you had a lot of anxieties and it was quite traumatic for you in your last delivery. However, for a cesarean section, it's also a major surgery, and it means that sometimes women will spend a few days in the hospital as compared to having a vaginal delivery. Are you following me?
I know that, but I don't want to go through this. I understand it's a surgery, but I am sure it's not going to be as traumatizing as my last delivery.
Fair enough, fair enough. Yeah, I mean, with the cesarean section, you've got a set date, it's a calm environment, and it eliminates the risk of you having any perineal tear from down below because the baby is going to be coming through your tummy. But looking beyond that, in terms of your recovery process, you might spend a few days in the hospital. It might be more challenging bonding with your baby. And even I understand you've got a 3-year-old, bending down to carry them might be a little difficult compared to having a vaginal delivery. Also, there are risks associated with surgery in itself. And anesthesia, because we will be giving you one for the cesarean section. With regards to the vaginal delivery, from asking you questions, I've gathered that you do not have any long-term complication following this perineal tear you had 3 years ago. So it's also reasonable to consider vaginal delivery in this case. Are you following me so far?
Well, yes, but if I do opt for a vaginal delivery, do you think I might get a perineal tear again? And if so, how much is the risk of me getting another tear?
About 5 to 7 in 100 women will sustain a further third or fourth degree tear, which is a tear that extends into the muscle of the back passage or the anus like you had previously. However, there are things we can do during delivery to help minimize this risk. But on the long term, only a cesarean section will be the only means to completely eliminate this risk.
Okay, so you're suggesting I have a cesarean section this time too?
I do feel that considering both modes of delivery, if you do understand the risk benefit, you can make a decision as to what you would like, and we are more than happy to support you through your decision. With the vaginal delivery, like I said, even if it happens again, the most important thing would be to identify during delivery, and then we would repair, and we could have a senior obstetrician midwives present during your delivery to help minimize the risk. Sometimes, depending on how things go during labor, we can give you a cut down below, but it's not routinely given unless we do think that you will benefit from it.
Okay, time's up.
Time's up.
Okay, time's up. But yeah, you can continue what you were saying.
Okay. Yeah, so going forward today, I can give you some leaflets to read about your options for mode of delivery. We can also organize another meeting in the next few weeks with the consultant to enable us to reach a final conclusion as to what you would like to do in this pregnancy.
Mm-hmm.
And just so you know, whatever decision you make, we will be supporting you through it.
Mm-hmm.
All right. Do you have any questions, Rita?
Well, I think I'll think about it and then get back to you.
Okay, that's good. If you have any concerns in the meantime, you can speak to your midwife, or we will be seeing you again to answer all your questions. Is that all right?
That's fine.
Thank you very much.
Thank you, doctor.
Yeah.
All right, okay. So how do you think it went?
Well, I think I need to work on my timing.
Yes, that's right.
Yeah, I think I need to work on my timing.
All right.
Yeah.
I just have a couple of things to tell you, right? The first thing is there's absolutely no problem in terms of communication. So your communication is very good, just that it has to be a little more structured, right? In terms of when you are counseling the role player, it could have been a little more structured, wherein you could have cut down on things. So you could have included more important things, right? Like explaining what is 3rd-degree and 4th-degree perineal tear. You don't need to do that right now because she's already had it once. I think she knows what that is. Okay, I'll start from the beginning. First thing which you could have worked upon was your timing in terms of information gathering, right? It went on for 6 minutes. You could have cut it short to 4 minutes, wherein you could have been a little more crisp. And in spite of that, you forgot quite a bit of history, right? You asked medical, surgical, allergies, but you forgot it's an antenatal patient, right? So you forgot social history, you forgot her, where she's working, how's her support, how's her mental health, what is her BMI, and these things, support and all of these things are a little important, especially the fact that she had a perineal tear and she might require support again, considering the fact that she has a small kid. Okay, so these are few things that were missed. What you did really well was you added that one sentence that I really like, that thank you for sharing this information. Is there something else that you want to add? Because this gives you an opportunity to get or retrieve whatever information you might have missed, or whatever important information you might have missed, right? And you offered examination, but you did not mention the chaperone. Examination is fine, it's good, but chaperone is important in terms of patient safety, right? So that was one thing that you missed. And in terms of counseling the patient, I think you did a pretty good job. Well, you empowered her to make a decision for herself. You did not force her into, having a vaginal delivery. But factually, a few things could have been altered. Like you told her that there are complications associated with cesarean section. Along with that, you could have added benefits of what a vaginal delivery could offer. Along with that, you could have told her that if you do offer her a vaginal delivery, what are the things you would be doing? Like she would be under a consultant's care, like, there would be a midwife involved, a senior skilled midwife involved. She can do a perineal massage in her antenatal period, how you can give perineal support to prevent 2nd-degree, 4th-degree perineal tear from happening. These things. I'll cover that in detail, but these are few things that you could have added as well. And when she said that, should I go for a cesarean section? You said, yeah, cesarean section is a reasonable option, but, you should not have just straight away agreed to it. You could have said that these are the two options that you have, and you can think about it, but you can very well go for a normal delivery. It shouldn't be a problem. All right. Well, I have sort of written down a template. Okay, this is not the ideal template. And for whoever is listening, I wouldn't suggest that you just copy it, learn it, and then say it in front of the examiners, because examiners do not like it. But this is just a way to show you how the station can be carried out. All right, Rukat, let's go through it. Yeah. So the introduction could be something like, hi, I'm Dr. What about control of latency? Yes, Shaima, I'm getting to everything. Just give me 2 minutes and I'll go through the entire template, and then it would be a little easier, and then we can discuss more, all right? Yeah. So you can start with the introduction. You can say, hi, I'm Dr. whatever your name is. I'm Dr. Pradnya. I'm one of the doctors in the OBS clinic today. May I confirm your name and age, please? And the patient will tell that her name is Rita Skeeter. She's 33 years old, right? And then you ask her, what would you like me to call you? Which Rugayat did, and I told her. Then you set an agenda as to what this discussion is going to be all about, which she did very well. You can say that I understand from your GP letter that you want to discuss about your mode of delivery. Is that right? And when she says yes, you go ahead and tell her that yes, we will be discussing about your concerns in some time. But before that, is it okay if I ask you a couple of questions to know more about you? And then we can discuss in detail regarding all the available options for you. Okay, that is how you set an agenda, so that you basically summarize what is going to happen in the next couple of minutes and confirm why the patient is with you right now. Okay. This is not just for Rukai, this is for all of you who are here with us today. Right. So let's start with information gathering. Let's go through one by one. Okay. So when you're starting information gathering, the best thing to do is start with an open-ended question. Okay. An open-ended question would allow the role player time to speak out whatever agenda she has in mind. If you start with closed-ended questions like, oh, did you have a third-degree perineal tear? Did you have flatus problems? Did you have fecal incontinence? Did you have this? And she'll keep saying yes or no. You are sort of limiting the role player, right? Let her talk, let her say everything that she has in mind. And then you can jump ahead to closed questions, okay? So what the role player is most likely to say is that she had long and difficult delivery, which was followed by a third or a fourth-degree perineal tear. And then she will insist that she does not want to have a normal delivery, or she does not want to have a vaginal delivery. She will insist that she wants to have a cesarean section no matter what. Now is the stage wherein you have to negotiate her, okay? Negotiate her in the sense, you don't tell her that no, it is not, a cesarean section is not indicated, or you don't tell her, yeah, you can have a cesarean section. You elaborate her concerns, okay? Before you do that, when she tells you that she had a difficult delivery, she had a difficult time, it was a bad experience for her, you sympathize with the patient, you acknowledge it, you empathize, you tell her sorry that you had to go through it. And then you tell her that, if I were in your place, Rita, I would have been anxious too regarding the outcome of my pregnancy. It's fair to feel that way. But you reassure her and you tell her that I will do my best to address all your concerns this time. But before we move on to talking about your concerns, is it okay if I ask you a couple more questions to understand your situation better? Normally, the role player would have covered all the points, but if not, these are the few questions that you should ask, which Rukayat asked very well. If the labor was induced or if it started spontaneously, how long did the labor last? What was the weight of the baby? Because yes, a baby weight of more than 4 kg is associated with 4.5 kg is associated with increased risk of perineal tear happening. Ask if any instruments were used, like Rukayat did very nicely. She used very good words like, was a cup used over the baby's head, or were some instruments used to help deliver the baby's head? So these things can be used in terms of layman words, right? So once the patient tells about the delivery, about how it was, how painful it was, what she had to do, and how exactly the baby's head was delivered, you ask her about the post-delivery recovery. You ask her, how did you recover? Did you have pain? After that, the most important thing is to ask about her symptoms. Okay, so in terms of symptoms, you will ask her if you lost control over your bowel movements, or if you lost control over your gas, or if you are passing gas involuntarily. Okay, because these symptoms are the most important, which are going to tell you about the further management. If she had symptoms after delivery, and if the symptoms are persistent, then it straight away would be a cesarean section for her this time as well. But if not, then there's a place for you to negotiate. Okay. After that, you would ask her about problems with her waterworks. In the sense, if you have any problem in peeing or if you have any problem in passing urine. After that, it's also an important part of the information gathering for you to ask if she had any difficulty during sexual intercourse, if it was painful, if she had any sort of dyspareunia, because that can happen as well. So you need to make sure that you ask about her sexual intercourse or any difficulty following sexual intercourse. But it would be wise to signpost about the before asking about sexual intercourse. Before you ask, just mention that my question might sound intrusive, but it is important for me to understand so as to formulate a better management plan for you. All right. I hope I'm making myself clear till now. Do you have any questions in information gathering?
Yes.
Yes.
No, I don't have any questions. It's clear.
All right. That's great. Okay. So once you ask about her previous symptoms of, bowel or bladder problems, then you ask now, do you have any symptoms right now? Do you have any symptoms controlling your bowels? Or do you involuntary pass gas, or do you have any problems with your waterworks now? Okay. After that, you just check about her obstetric history, ask that if you've been pregnant before, ask about her menstrual history, or check about her current pregnancy, right? How's the pregnancy going so far? Any problems? How have the blood tests been? How have the scans been? Just to, create a rapport, ask about the baby. Have you named the baby? If she says, I've named my baby John, just to create a rapport, say that, oh, that's such a lovely name. How's John kicking inside? Just to make her feel comfortable. Okay, these are good things. And these stations, most likely will have a extra lay examiner who is going to look at all these things about how you talk to patients, how empathetic you are, how sympathetic you are, and these things are going to bring you extra brownie points from the lay examiner, who is again very important, right? Then you ask about the blood group, if she has any reservations for blood transfusion. Rukayat, I think we wasted a little bit of time here, right? You could have just said, do you have any reservations for blood transfusion, instead of saying, if you require any blood transfusion, because then she might get anxious and be like, why am I being asked about it? So just a simple change in sentence. Yeah.
Okay.
All right. Okay. Now, rest of the history, I think you can just move through it quickly in terms of, were your periods regular? Do you have any medical problems for which you're following up with your GP? Any surgeries in the past? Any allergies? Any family history of concern? Just to touch upon social history, do you smoke? Do you drink? Do you consume any recreational drugs? And her social history, ask what she does for a living, who does she live with, is she well supported at home? Also check her weight to height ratio, because again, this is a risk factor for a 3rd, 4th degree perineal tear. Also, increased BMI would increase the risk of labor dystocia, would increase the risk of instrumental delivery, etc. So that is important here. Also check about her mental health in terms of, by asking her, how have you been feeling in the last couple of days? Okay. And one sentence that you did ask, which I really like, is, thanks for sharing this information with me. Anything else that you would like to add? Okay. All right. Now, regarding examination or offering examination, there's been a lot of confusion, especially since the Osler system came in place, because it's an online exam. You're not really, meeting the patient, or the patient is not getting up from their place. And you're even in a face-to-face exam, you're not going to get up from the table and go and examine the patient. Okay. So I think the wise thing to say here would be, I would like to offer you examination in the presence of a chaperone. That doesn't necessarily have to be right now, but you need to mention the word examination, because unless you do that, if the examiner has some examination findings, he or she is not going to give it unless you utter the word examination. So you can say that I would like to offer you examination in the presence of a chaperone to see the size of the baby, or, to check the baby's heartbeat and things like that. But do say examination, because otherwise you might miss out on important information and lose some points from the information gathering. Okay. Also, one important thing was to ask for a patient's previous papers, right? Now comes the important part of counseling the patient and addressing her concerns, right? I think you did this very well, Rukayat. Another way to do that would be you acknowledge and you say that I understand that you had a previous 4th-degree perineal tear and you want to discuss your options regarding the mode of delivery this time. Am I right? Is there anything else that you would like to discuss? So if there is anything that she wants to tell you, she'll tell you right now. Again, say sorry that you had a difficult delivery the last time, but it is quite difficult to predict who is going to get a perineal tear. Okay? So even people who have risk factors might not get it. And a lot of times people who do not have risk factors still get it. So it's very difficult to predict it. But in your case, you did have a couple of risk factors, like it was your first pregnancy, your labor was induced, and your labor lasted very long. So these could have been the risks that led to a perineal tear. Okay. So this role player will say that I don't know. I just want to have a cesarean section. I don't want to go through the anxiety of having another vaginal delivery again. So you say, you acknowledge her, you acknowledge her concerns, you empower her to make the decision for herself, which you did very well, Rukat. You tell her that I understand, Rita, that it's a woman's right to choose her mode of delivery, and you can make that choice for yourself too. If you allow, I would like to speak about both the options that are available for you. And then once you're well informed, you can make a decision for yourself. Okay, so just to, she's in that state of mind wherein she's saying, I want a cesarean section, I don't want anything else. By telling her that it's okay, you can do whatever you want, but just listen to me first. So you bring her a level down, you calm her a little. It's like, a kid asking for a toy and you tell the kid, no, you won't get anything. Rather, you negotiate with the kid and say, okay, maybe once you finish your homework, we can go do something, right? Something like that. So you tell that we will discuss both the options and then you're free to make a decision for yourself. That's how you negotiate with the patient. So she'll be like, okay, fine, what's the harm in listening anyway? But never ever say that, oh, a cesarean section, that's not indicated right now. You can't have a cesarean section. If you say that, she's going to get angry and then she's going to leave. Right. So you say that you're absolutely right in saying that a cesarean section is going to decrease the likelihood of another perineal tear. And you wouldn't have to go through a long labor. There wouldn't be any anxiety regarding the outcome of the baby. But now is the time when you tell her that what are the complications associated with cesarean section. Okay. So you tell her that it is associated with an increased risk of blood loss. There would be more pain. The recovery would be delayed. Like you said, Rukai, you have another baby to take care of at home. You can, it would be difficult. There could be infections in the wound. There could be injury to other organs nearby. And sometimes you might even require blood transfusion. Okay, so she'll start thinking, oh, there are complications associated with the section as well, cesarean section as well. Right, so you at least got her in a place where she's negotiating or she's trying to understand what you're trying to say. Okay. So at this stage, stop and ask her, are you with me so far? Give information in small chunks. Don't overburden her with information. Okay. Now is the time when you introduce that, as you don't have any symptoms right now, as in you don't have any fecal symptoms, any symptoms with passing gas, it means that your anal muscles have healed well. And now you can have a normal delivery. There are no problems with it. And now you tell her the good things about vaginal delivery. If you have a vaginal delivery, your recovery would be better. You can go back home earlier. There would be lesser pain. You wouldn't require any, there's a risk of risk of bleeding would be lesser. You would heal faster and things like that. And then you tell her that we will make sure that the risk of you getting a perineal tear would be lesser this time. And we will do extra special things to prevent you from getting another perineal tear. And you tell her that if you choose to have a vaginal delivery, you would be under a consultant-led care. Okay. From now on, in the antenatal period, you and your partner can start doing perineal massage until your baby is born. Now, this is known to reduce the risk of tearing. During the time of delivery, we will offer you perineal protection, which is also known to decrease the risk of tearing. We will work with you and we'll choose a position that both of us are comfortable with, that will be beneficial for you, and that will also reduce the severity of tearing. There will be a senior midwife looking after you. Okay, we will give you warm compression, and as the perineum stretches, as the baby's head stretches the perineal tissue, this will also reduce the severity of training. And the midwife will support your perineum as the baby is born, and we call this hands-on birth. We'll do all of these things to make sure that you do not have another perineal tear. And she'll be like, oh, so what is my risk of having another perineal tear? So you can say that we will take all the precautions, but in spite of that, you do have a 5 to 7% risk, or a better way of saying that would be you have a 5 to 7 in 100 risk of having another third or fourth degree perineal tear. So she might, if there is time, she might ask you questions like, oh, my baby seems bigger than my previous baby. I think that would increase the risk of me having a tear. So you can reassure her and tell her that you would be reassessing the baby's weight again at 38 weeks. But having said that, a big baby does not necessarily mean another tear. It's very hard to predict. And, that would again not be an indication just to go for a cesarean section again. She'll also ask you that, there people do give tears or cuts in the vagina, which is known to prevent, or is it going to prevent another tear? So you tell her that studies have shown that the cut on the vagina, or episiotomy as we call it, it is not going to decrease the risk of a perineal tear, and the need for an episiotomy would be assessed when you are in labor. If there's a need, we would give you an episiotomy or a cut on your vagina, but if not, it's not going to protect against a perineal tear. Okay. And once you do that, you ask her before you end the consultation, you ask her, so Rita, were you able to make a decision for yourself, or would you like to think more about it? So she'll probably tell you something like, I'll go home, think about it, I'll talk to my partner, etc. So you tell her, all right, do you have any more questions? Never end a session or never end a consultations without asking, do you have any more questions for me? She'll probably say no. And then you fix an appointment with a consultant. Involve a consultant in such cases. Okay, Rukait, I think you missed involving your consultant. So you say that I'll fix an appointment with my consultant and I'll provide you with some written information regarding the discussion we had today. You ask if that sounds okay, or if she has any more questions, and you end it on a good note. So starting on a confident note and ending on a good note is very important. So anybody has any questions regarding the station we've covered so far? Shaima, I think you had a question, but I hope I've answered it now. Oh, sure. Zarpa, yes, you can mention it. That would be one point in your communication with colleagues domain. Yes, you can definitely write back to the GP. There's no need to add consent. You can just tell her that I'll be writing back to your GP if that's okay with you. It's nothing really to hide. Yeah. Any other questions? Does anybody else have? We'll move on to the breakup in terms of each domain. So I believe whenever you're doing a station, it is very important to look at each domain, because it's very easy to miss out the patient safety domain, or the applied clinical knowledge domain. Shaista, of course, you can use terminologies like vagina, uterus, things that you might understand, but don't use terminologies that are purely medical, like not able to think of something purely medical. But yes, you can use like normal terms that you use on a day-to-day basis, like anesthesiologist or a neonatologist, or say uterus, vagina, vulva, things like that, which she can understand. But you don't know really what nurse she is, or what department she's working in and what she's comfortable with. So to be on the safer side, just use layman term, because when you're conversing with another person, it's better if you're talking in like a normal layman person than a doctor. Okay, other than her not understanding, it comes across as somebody who's a little too arrogant, or who doesn't want to go down to their level to talk. Yeah, Just to be on the safer side, use almost all layman terms. Just these generic words you can use, I think, like vagina, vulva, cesarean section, and forceps delivery, vacuum. These things I think you can use because people know about these things. Okay. Does anybody else have any questions?
Hello. Hello.
Hello. Yeah, tell me. Hi. Is this
Yeah,
Sadia?
the question
Hi,
is not regarding this. Yeah, I'm Sadia.
yeah, Sadia.
Hello.
Yeah, I'm here. I can hear
Yeah,
you.
the question is regarding not this scenario, but if the patient comes after the follow-up, after the perineal tear at 4 to 6 weeks, and she still have the symptoms, and
Yes.
she is not following the physiotherapy regularly, and then when we say that your symptoms are not improved, we send to you the specialist. Then
Right.
she asked that after we advise that they will do some scans and check, and they will advise you further treatment. That patient then asked that what treatment they will offer. So at what time, what we will say to her?
Okay. So as an ST5, you're not really expected to know what a colorectal surgeon is going to do for, fecal incontinence or
Mhm.
gas incontinence and things like that. As your rule, you should be a safe doctor and refer the patient to the colorectal surgeon and tell them that they will be taking care of your problems. Okay. And other than that, you also
Mhm.
need to reassure her and tell her at 4 to 6 weeks that right now you are symptomatic, but at the end of 1 year, almost 6 to 8 out of 10 people become asymptomatic. Just to reassure her, you can definitely
Mhm.
tell her that. And in terms of the symptoms, I think it is wise not to comment on it being an ST5 in OBGYN because that's a totally different specialty and we don't really know what they do. Yeah. Okay. So Mridu has a question. If patient comes with recurrence of symptoms at 6 weeks post-delivery, then we refer to bowel surgeon or gynae specialist. So the GTG says that
Yeah,
you
my
can
friend,
either
one friend said that she asked me that did they put the colostomy bag? Is it that
colostomy bag for a third
she
degree
the
perineal.
role player? Yeah, role player said
Mm-hmm.
did they repair it and then put that bag? My friend has it.
Oh,
The
okay.
role
So
player asked from the
okay.
candidate.
So when a role player says that will they put a colostomy bag, you tell her that a colostomy bag is usually attached to your bowel, that is to collect the poop, and that happens if there's an injury to the bowel and not in a third or a fourth degree perineal tear. So it is very
Mhm.
unlikely that in your situation, if that happens, you would require a colostomy bag.
Okay.
Yeah.
Mhm.
Okay. Yeah, I hope that
Thank
helps.
you.
All right. So if Ridu has a question, he says that if a patient comes with recurrence of symptoms at 6 weeks post-delivery, then we refer to bowel surgeon or gynae specialist. So the guideline says that you can either refer these patients to a colorectal surgeon or a gynac with special interest in third or fourth degree perineal tear or oasis. So you can refer to either. While doing that, you would not be wrong if you refer to a colorectal surgeon also or to a gynae specialist who has special interest in oasis, saying this would be a little difficult. So you can say, colorectal surgeon, but either is fine. You are, okay. So, okay, let me go through the other question. Can we initiate incident report at 6 weeks? Well, Shaista, the incident report should be initiated as soon as she's had delivery. You should do all the 4 things of clinical governance. You should document everything. You should initiate a DATX or an incident report. Okay, you should assess the risk for any DVT prophylaxis if she needs, right? And you should what is the other D? You should document. You should fill a DATX and you should debrief the patient about what has happened. Okay, so you should do all the 4 things and that should be done immediately. Okay. Also, her future mode of delivery. Darshana, did I get your question right? Debrief, duty of condor. Yeah. So this particular patient, Darshana, this particular patient can very well have a normal delivery because even after delivery and at the 3 years follow-up when she's come with another delivery, she's completely asymptomatic. So there is no indication for her to have a cesarean section and you have to be blunt in telling her that. For the other patient, the one who is symptomatic, if the patient is symptomatic at the end of 1 year, or if the patient is symptomatic when she's pregnant again, the only option for her would be to have a cesarean section. Okay. Even if the patient is not symptomatic and her endoanal ultrasound is abnormal, which was done at the 6 weeks follow-up, even then she would be a candidate for an elective cesarean section. Okay, so Zoiba has a question. If patient is symptomatic at the moment, what will be the management options? Same here. So if the patient is symptomatic at the moment, you would offer her a cesarean section. Being symptomatic in the sense leaking gas, leaking stools of feces, or having an abnormal endoanal ultrasound, having an abnormal manometry, all these things at the end of 1 year, or when she's pregnant with another child, would amount to her requiring another cesarean section or a repeat cesarean section as a mode of delivery. So you would counsel her accordingly, right? Yeah, any other questions before we move on to looking at the domain-wise breakup and see what points should be covered under what domain? You're welcome, dear. You're welcome, Zoiba. Zobia. Zobia, is that right? Zobia Munaf. Perfect. Okay, right. So in information gathering, whenever you're going for exam, right, there are a certain few things in each domain which you have to get ticked. If you don't get those things ticked, you will lose marks, right? For example, in this patient, the most important thing to ask was regarding her, what events that led up to the perineal tear and the symptoms following it. Okay, the symptoms of fecal incontinence, the symptoms of flatus incontinence, and if she has any pain during intercourse. Okay, one important thing would be to request delivery records from the previous hospital and to review whatever difficult experience she's had with the delivery. Okay, that was one. Another important thing regarding information gathering. In terms of communication with the patient and families, such negotiation stations are what going to test your communication skills to the core. Okay, that there will be times when the patients are extremely adamant, they're extremely difficult, they're just not going to agree. But you as a candidate or a exam candidate are not supposed to lose your cool. And one pointer, if you think that the patient has not got convinced, that does not mean that you failed the station. Okay, towards the end there might be patients who will be like, who would still be in a state of denial. That does not mean that you've not passed the station. You should do all the things that you're supposed to do. You should empower the patient, you should allow her to make a decision, you should give her all the options, not force her, not push her to make a decision you think is right. And that is all that is expected out of you. Okay, so during communication, you have to be very empathetic with the patient. You need to be very understanding of the anxieties. Okay? Anytime she's telling you that I had a difficult time, with your not just with your words, with your expressions and with your body language, feel sorry for the patient. Say that I'm sorry you had to go through it. I can imagine it must be difficult. I understand you had a terrible time. Sorry that you had to go through it, and things like that. Okay. Also, during communication, you need to explain the patient about the pros and cons of both cesarean section versus normal delivery. I did that in the template that I just showed about how it can be done. Okay, you start from one end and take it to the other end. Okay, start with the good things about cesarean section. Okay, then you tell about the complications of cesarean section. Then you mention how normal delivery could be beneficial, and what you would do if the patient had to have a normal delivery. What are the extra things you would do to prevent another perineal tear from happening? Okay, take it in a structured format like this, right? And towards the end, let the woman make a decision. Let her make an unbiased decision. You do not push her. Okay, now this was regarding the communication. Now, in terms of communication with colleague, very important to involve the consultant. Fix an appointment with the consultant. Tell the patient that you will be in a consultant-led care. And do involve a senior skilled midwife. Okay. If a patient seems very distressed about her previous delivery, if she seems like she's had something terrible and she's not able to get over it, if she feels very sad, then you just reassure her and refer her to a psychologist or a psychiatrist. Okay, so these are three things in communication with colleague that you need to keep in mind, right? Patient safety, I think the most important domain, but very easily missed. One would be confirming her identity, her name and age. Examining in the presence of a chaperone. Okay, don't forget, whenever you utter the word examination, please always make sure to use chaperone. I would like to examine you in the presence of a chaperone. Okay, this one sentence can be used in all the stations. Okay, empower the woman to make her own choices. Don't force your choices on her. And these are generic for all. Rule out allergies, check blood group, check reservations for blood transfusion. And this delivery should be conducted by a skilled midwife for this particular station. Okay. Now, applied clinical knowledge was quite important in this station because it was a station of 3rd or 4th degree perineal tear. So you need to mention, or you need to tell her that risk factors or having risk factors do not allow for accurate prediction of OASIS, right? Some people might have risk factors and still not have a perineal tear, and some people might not have risk factors and still get it. So there are risk factors, but they do not decide about the outcome, okay? Right? Also, you need to put in or mention it somewhere when you're counseling the patient that episiotomy is not going to help, okay? So she might be like, just give me an episiotomy, that's going to prevent a tear. But if you agree to it and if you say, yes, yeah, we'll do that, then you will lose your mark in applied clinical knowledge. Okay, you tell her that episiotomy is not going to offer protection against a perineal tear. You need to also know that perineal massage during antenatal period is going to be protective. Warm compression, perineal protection at crowning. Okay, these things are going to be protective. Instrumental delivery would be associated with an increased risk. If a patient asks, you need to know about the incidence. So the overall incidence is 3 in 100. In a multigravida, it would be 2 in 100. And in a nulligravida, it would be 6 in 100. Okay. If she asks that what are the risks that I might get it again in the next pregnancy, you need to tell her that there's a 5 to 7 in 100 risk of you having a similar tear in the next pregnancy. All right. And if the patient is symptomatic, or if she had an abnormal endoanal ultrasound, you would request for a cesarean section. Okay. So these were the points according to the 4-5 domains that were being tested. So whenever you're doing the station, if you go through it domain wise, I am 100% sure that you're not going to miss any points. Okay. Think so. This was the discussion regarding simulated patient task of a negotiation station of counseling regarding the mode of delivery. We've reached towards the fag end of our station or of our session. I was wondering if you have any questions. Now would be the time to ask. Any questions after we've discussed the domain-wise breakup? Oh, thank you so much, Atiya. Thank you so much, and thank you so much for being with me in the session. Thank you, thank you. I think it is my part 3 which has made me more empathetic, even as a person. So I'm sure once you all go through it and once you clear it, you will all become very empathetic doctors. It's a lovely, lovely exam. It's my favorite part of the three parts of MRCOG. The part 3 is the best. Okay, so I'm guessing you don't have any questions, but if you do have questions, yes, all the best to all of you, and I wish all of you lots and lots of success. And I hope that you clear in the November exam. But if you do have any, thank you, Rukai. Thank you for being with me. It was lovely interacting with you. Thank you. If you do have any questions, you can either get in touch with me or you can get in touch with Fatima. She's shared her WhatsApp link. How to look for time and face-to-face. Oh, well, Mridu, there would be a small alarm or a clock sort of a thing. There would be some this thing made for you to make sure that you are aware of how much time is going on. And well, in the Ostler, there is a timer on the screen, but there will be a small watch, I'm sure. your wristwatch? Well, I don't think so. I think there will be a timer which will be, a timer which will be ticking. Looking at your wristwatch during an OSCE wouldn't come across well. Okay, might seem like you're in a hurry to leave the session, or you're in a hurry to go out, which might make your role player uncomfortable. So I'd suggest don't do that. Don't look at your wristwatch. All right, so I guess there are no more questions. But if you do have any questions, you can get in touch with me, or you can get in touch with Fatima. She's shared a WhatsApp link here in the chat box. Thank you so much, everyone, for being with me. It was a great session. Looking forward to more such sessions. And if you have any suggestions on what module you want to discuss, please let me know and we'll do that. Thank you. Thank you, Rukayat. Thank you, everyone else. It was great. It was a great time. Thank you. All right.
Thank you very much.
Thank you. Thank you, Rukayat. Bye. Bye-bye.